Good morning, I'm Alexis Del Cid. We had hoped to bring you our live program today, but it needs to be rescheduled. So please enjoy one of our favorite past episodes in this Encore presentation.
Coming up today, what started as a sinus infection and unusual exhaustion turned into a life-threatening discovery. Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Today's story is a personal one for me. Kathy Kirby is my cousin, and her experience is a powerful reminder that cancer doesn't always come with obvious warning signs. Joining us live here in studio is Kathy Kirby. Always great to have you.
Thank you for having me.
Great to see you.
Great to see you.
So glad to have you here with us and with me today.
Exactly.
Also joining us today is Chief of Colon and Rectal Surgery, Dr. John Ashcraft. Always love having you with us.
Thanks. Thank you.
Always lots to talk about with you. Joining us via Teams is Kathy's medical oncologist, Dr. Rayed Al-Rajabi. We're going to check in with you here in just a moment, Dr. Al-Rajabi, but great to have you with us this morning. Kathy, I want to start with you first. How are you feeling today?
I'm feeling really good. Very thankful to be feeling this good. No complaints.
Love to hear that. So before you were diagnosed, you were getting ready to head to this trip to Florida, which I guess you've taken many times before. You almost ignored some signs and how you were feeling. Describe what you were feeling. What happened?
Well, getting ready for the trip, I was very busy checking all the boxes and noticed that I had kind of a ringing in my ears, a little bit of sinus congestion, and I thought, okay, do I call my primary care doctor and have him give me something, or just wing it? And normally I would have just went with it, looked for a CVS, grabbed something, but there was kind of a nagging feeling. And I'd also noticed recently, since my birthday, which was March the 7th, just a tiredness that I hadn't experienced before. So I called. He said, well, run down. He said, I'll give you something. So he said, well, while you're here, let's do a blood panel. We haven't done one in a while, so no big deal. Went back home and continued packing, getting ready. And the next day, the phone rang, and he said, when do you leave? And I said, well, we leave in the morning. And he said, well, you're not going to go. You can't go on this trip. And I kind of jokingly said, but I'm ready. For once, I'm ready. And he said, where's your husband? Where's Randy? And I said, he's at work. And he said, you need to call him, and I need you to get to the emergency room right now. He said, you're losing blood somewhere, and we don't know where. He said, your numbers are not good. Well, still, I'm like, well, this can't be me. I mean, I don't feel that bad, do I? You know. But we did. I called Randy. He came and got me. You kind of go into a disbelief situation where, okay, I'll do this. Got there, it was a long night in the emergency room. I had a blood transfusion. Things kind of started taking place rather quickly. Called the doctor in. She thought it was maybe an ulcer, bleeding ulcer. They did an upper GI or whatever. It came back negative. Randy had mentioned to one of the doctors that it was time for my colonoscopy, but you know, he thought maybe they'd do them both at the same time. Anyway, long story short, they scheduled a colonoscopy, and it came back stage 3 colon cancer. You still kind of go into a disbelief. You're like, well, how can that be? You know, looking back now, that this has been a journey I've been on now for almost a year, there were signs that I truly ignored. Nothing big. Even the indigestion part, I joke, my family could do a antacid commercial. We've always got a bottle of something in the fridge after a meal or in the cabinet, but there were other nagging things. So,
well, I want to bring in Dr. Al-Rajabi because Kathy presented with anemia, she mentioned. How often does this internal bleeding that she mentioned lead to a cancer diagnosis?
Well, anemia is one of the common presenting symptoms of colon cancer, especially on the right-sided colon cancers. A lot of folks don't realize that they're bleeding and it's microscopic when it happens on the right side. Left-sided colon cancers, you could potentially see the red blood, and that could alert you. But yeah, it's a very common side effect, common symptom of right-sided colon cancers.
So your doctors tell you your hemoglobin was dangerously low. You get to the ER, as you mentioned. Did you have any clue that it was this serious? You said you felt ill, but not cancer ill.
Not cancer ill, no. I could tell by the motions of everybody in and out. I could tell it was probably a little more serious than I was taking it. When she came back, they decided to do surgery immediately. It was robotic surgery. Dr. Liu was my doctor at the time, and she even mentioned that she felt like the margins were clear enough that they could go in, remove the tumor, and then I would have treatment after. The surgery went fine. I mean, honestly, and I don't think I was drugged up to where I didn't realize anything, but I didn't have any complications. So.
And you had your surgery in Springfield, and we're learning there's like 6 degrees of separation from your surgeon, because you know Dr. Liu.
I do know Dr. Liu. She trained here at KU.
And we're going to learn that your doctor, one of your oncologists, also knows Dr. Al-Rajabi.
Yes,
so lots of good connections.
I was in good hands.
Dr. Ashcroft, Kathy's hemoglobin was extremely low, as we've mentioned. How does that impact surgical risk and preparation?
Yeah, so 60 to 70% of patients that show up for after a diagnosis of colon cancer will be anemic. It's actually kind of showing up as one of the more common ways we find it. We talk about symptoms of abdominal pain and change in bowel movements, and like Dr. Al-Rajabi mentioned, blood in their bowel movements. But on the right side, you don't see that bright red blood that we typically talk about. It can be dark, you can have black bowel movements, or it can just be very subtle and hidden where you don't notice it. And so when a patient shows up anemic, the issue that we have if we're going to surgery is that if they're so anemic they may require a blood transfusion. That impacts our survival rates and our success in surgery. Anemic patients, when they require transfusions during surgery, that lowers their immune system and what we call immunosuppresses them. And when they're immunosuppressed, then unfortunately cancer cells can be a little bit more aggressive inside the body. And so we see decreased survival rates when patients require transfusions.
Well, as I'm thinking about it, we're making the blood connection, but you're right. The blood in the stool that we talk about, that would make sense, the loss of blood. Kathy, your diagnosis came, you're my cousin, if you're just joining us. This came as a shock to the family, but I guess in a way it shouldn't. Any cancer diagnosis comes as a shock, but we have a family history of colon cancer. Here's a picture of some of the women in our family. Here's you and I back in our heyday. And you're the oldest cousin, if I could say, back when we were babies, if I can say. But you know, family's everything to us. Our Aunt Anita passed away of colon cancer. We just found out that our Uncle John, who passed away recently, had colon cancer. We have breast cancer in our family. Now you're diagnosed with colon cancer. Dr. Al-Rajabi, what is the family connection? What should we be concerned about?
I think any family member or any patient that has a first-degree relative that has colon cancer should be genetically tested for the possibility of a hereditary issue. Any patient that's below the age of 50 also should be tested for any hereditary risk of colon cancer. Unfortunately, the rates of colon cancer are going up, but it's mostly patients that don't really have any inherited risk, and it's in younger and younger individuals. But the thing that usually triggers a genetic counseling appointment or evaluation should be the patient's age and their direct relatives. If there's any doubt, we have some wonderful qualified genetic counselors here at KU that could sort through the family history and figure it out.
Dr. Al-Rajabi, when you reviewed Kathy's case, is there anything that stood out to you early on that you saw?
So when I reviewed Kathy's case, we had been working on a study here at KU called the Atomic Study. And Kathy was one of the folks that we studied on this trial. She had 3 out of 31, I think, lymph nodes involved with her surgery, and making her a higher risk of recurrence. Especially, she had a very unique molecular picture of her cancer. Her cancer had a unique genetic picture that would respond really well to immunotherapy, and we had done this study with multiple cooperative groups across the nation and had completed it a few years ago. and all my patients had done very well on it. And the study wasn't really published, but when we were talking about this, me and Kathy, but I really had a suspicion that patients were going to benefit from all this, and lo and behold, last June it changed practice across the world because of that study. So that's the uniqueness of her cancer, is that immune marker. She had something called microsatellite instability, and we talked about what that implication has on her survival, and what we could potentially and how we could potentially improve that.
And Kathy's cancer was a rare form of stage 3 colon cancer. What else does that mean in terms of aggressiveness and treatment planning?
So microsatellite instability in a colon cancer causes very aggressive tumors. Her cancer was poorly differentiated, and they rarely respond very well to chemotherapy. On the contrary, some cases, if you give them chemotherapy, they actually do worse because you're suppressing their immune system. So it's very critical to take that in mind to improve odds. Right now, immunotherapy is indicated in the widely metastatic patients with microsatellite instability, and we know it's superior to chemotherapy. And that's why me and Kathy talked about adding immunotherapy to her chemo to improve her odds when I saw her. But this is a very unique. You only see it in about 4 to 8% of patients overall, and in stage 3. So it's a very rare situation.
Dr. Ashcraft, what does it mean from a surgical standpoint, stage 3?
Stage 3 indicates lymph node positivity usually. That's usually identified by scans done before surgery, as was probably done with you. The colonoscopy identifies the tumor, and then we do CT scans to identify any spread of the disease, be it to the liver, the lungs, but also to the regional lymph nodes around there. In your case, and in any case of stage 3, the goal of the surgery would be to remove all of those lymph nodes, or as many as possible. One, so we can get accurate staging, because with accurate staging, then Dr. Al-Rajabi can proceed with planning his chemotherapy, whether it's needed or not needed, and what plans we need after surgery. But also so that we can try to decrease the chance of recurrence.
For people watching who think colon cancer always causes stomach pain or bowel symptoms, why can the signs be so subtle and missed?
Yeah, so the pain that you get, the crampiness, the nausea, vomiting, things like that, that will occur when the bowel gets a little tight, when it starts to get narrow or strictured. But that doesn't happen sometimes until very late. And so we want to catch those subtle signs, like you mentioned early, if we can. Usually fatigue, you can get weight loss, nausea, vomiting, you can see blood in the bowel movements as we described and things like that. But unfortunately, until the tumor starts to get larger, the symptoms can be very subtle.
And why is it necessary to sometimes delay the treatment until fully recovered from the surgery?
Yeah, so as in your case, surgery up front was warranted and actually was the ideal thing to do. And so once we want to proceed with surgery so we can get that tumor out, accurately stage you. The scans we get, they're good at staging, but they're not perfect. And so really the pathologist gives us the accurate stage. And so once we get the tumor out, we can get that accurate stage. But that does mean that the kind of catch to that is you have to delay treatment. You need the body to heal. The chemotherapies that Dr. Al-Rajabi prescribes, they're wonderful treatments. We need them. They improve survival. They're tremendous in how we treat colon and rectal cancer these days. But they also inhibit healing, and you need that healing to happen. Otherwise, you'll have complications from that reconnection that Dr. Liu gave you, or from the healing from the abdominal walls. So we typically like to wait. I beg my oncologist for 3 to 4 weeks, but if it's a really aggressive tumor, or if it was an emergency and we really need to be prompt with it, we'll go as low as 2 weeks, but we discuss the risks with the patient.
Dr. Al-Rajabi, you wanted to add to that?
Yeah, I think it's very important for patients to heal after their surgery, because especially we're going forward with chemotherapy and drugs that could also hinder their recovery, and patients have to be strong enough to really withstand some of these chemotherapies. Fortunately, the chemotherapy for colon cancer is not that hard. And it's always a good time to seek a second opinion. You know, if there's something odd, like Kathy's case, see if there's anything out there that may be of benefit, like a trial. If our trial was open, Kathy would have enrolled on it. So I think it's necessary, and we've seen with multiple studies that it doesn't harm in waiting unless the cancers are pretty aggressive.
Well, be sure to ask your questions. You can use the chat on YouTube or Facebook. You can email the Medical News Network. That information is there on your screen. Dr. Ashcraft, that surgery was needed pretty quickly, but Kathy, in your case, your surgery was delayed a little bit because of a Springfield tornado, I understand. No surprise of that, but
right.
That's a complication.
It was a complication, and nobody expects the weather to interfere with something as important as surgery. My surgery was scheduled for a Monday, and I was just waiting for them to come and take me down to surgery. And sirens went off, and of course everybody scrambles. And I kind of knew then, I thought, okay, because she told me what number I was on the surgery list that day. And I thought, okay, this isn't good, because it was taking longer and longer to kind of regroup everything. So it got shoved to a Thursday, which was fine. I mean, you're there. It's just a couple more days of waiting. Like I said, surgery went fine. I had no complications. Recovery went fine. I think I was right at the window of time was about 4 weeks. That was my cutoff. And then Mercy reached out as far as setting up oncology appointments. And I have a younger brother. I have 4 younger brothers that tend to take the bull by the horns, and they called you and said, wait a minute, we may want you to go to KU, and which I had no problem. A cancer diagnosis, you kind of feel like you're walking in the dark until you get information. And the more information you get, which is great, can be more confusing, because then you've got so-and-so saying, I wouldn't go there. So we made the choice to come to KU, which was a very wise choice. We have no regrets in doing that. And then come to find out, when we had our first visit, Dr. Al-Rashabi said, you live in Springfield? And we said, yes, which we had totally planned to just, whatever it took to come to Kansas City, to camp and live, whatever. And he suggested having my treatments done in Springfield, which has been a godsend. Just the recovery part, it's been a blessing to be able to come home from chemo feeling kind of rotten and go lay in my own bed. But yeah, that was a blessing to offer that to us.
Well, you wanted that second opinion.
I did.
Your brothers are bossy. I'm kind of bossy, and
it's a family.
It's a trait.
It's a trait,
and we can't.
Not a bad one.
Sorry,
not a bad one.
It's just the way it is. We got you into Dr. Al-Rashabi, and we're so glad that we did. Dr. Al-Rashabi, on that note, what would you say to someone who wants a second opinion but might not know how to go about doing it?
So of course, our website can direct patients to our navigation team. We have an excellent navigation team that will collect your information from your institution, bring everything and organize everything before your visit for the physicians to evaluate you. I think second opinions are critical, especially in complicated, rare cases like Kathy. I think it doesn't hurt to get peace of mind, we can always weigh in, and just like in Kathy's case, if it's not a clinical trial that you need to absolutely be at KU, we are more than happy to work with your local team to arrange the treatments and work together to really make it as easy as possible for our patients. Because we know in Kansas, a very large portion of our patients have to drive at least an hour and a half just to get to KU. And we want to make it as easy as possible for them.
Well, and it really benefits patients. And as we mentioned, kind of a 6 degrees of separation, because you happen to know her oncologist and team down in Springfield, so that was a benefit. But even when you don't, you're working hard to make sure that they can, because it's such a benefit to be able to be close to home. So you're always working hard
Absolutely.
to do that. Dr. Ashcraft, we were mentioning the surgery that Kathy had. Walk us through just what colorectal cancer surgery typically involves, and what patients might expect those few days and weeks afterwards.
Certainly. So as Kathy mentioned, she had her surgery done robotically, which is wonderful. Smaller incisions, which would be attuned to like laparoscopic surgery. Both of them minimally invasive. So the idea is smaller incisions, less pain. Of quicker healing, quicker back to life, as opposed to the old school large incisions that we sometimes have to do and still do. But if you go with minimally invasive approach, typical hospital stay after surgery would be 1 to 2 to 3 days. And then once you go home, no heavy lifting whatsoever. We typically, in our protocol we have here, we don't use a lot of narcotics for our patients. We know narcotics inhibit bowel function and slows healing, and so we try to stay away from that. And we've been very successful with it too. And so patients don't have a lot of pain with minimally invasive surgery. When we go to open surgeries, that's a different thing. Then we're talking about epidurals for pain control while you're here in the hospital. We're talking about the use of narcotics afterwards, because that's a really big incision and it's quite tender and painful. And the hospital stay for something like that is probably closer to 4 to 5 days.
Dr. Al-Rajabi, let's talk about the treatment that you put Kathy on, the chemotherapy and immunotherapy.
So we worked with Dr. Snyder and the team locally to try to get this immunotherapy approved with her chemo. It wasn't standard of care, so insurance gave us a little bit of trouble. So the ATOMIC study looked at comparing standard chemotherapy, which is FOLFOX, versus FOLFOX and Tecentriq or atezolizumab. And what we found when the study was published this year, I think it was last June, the early data shows that there was a 50% reduction in death and recurrence of cancer when you added immunotherapy. So a very significant improvement in survival in patients. So I think this has changed practice. Now this is FDA approved and everybody can have this treatment, but at the time we weren't 100% sure, and I think having access to folks that have gone through studies like this really helped us figure out the best option for Kathy.
And tell us about immunotherapy and the different types there are.
So there's several immunotherapies, and we're actually doing a study now to look at actually giving immunotherapy before surgery in very advanced disease like stage 3, and seeing if that would actually wipe out the cancer before surgery. We have achieved that with rectal cancer. Patients that have the same marker that Kathy has in rectal cancer are rarely needing surgery anymore, because we have immunotherapies like dostarlimab, which is a second-generation immunotherapy that we can give them before possible surgery. We still keep surgery on the table, of course, but a lot of patients, about 100% of them, have achieved a complete response before even needing surgery or radiation rectal cancer. So we're actually looking at that in colon cancer right now and giving 2 months of immunotherapy. Their patients are still going to surgery, but we're going to see if moving the immunotherapy up front may help us even avoid things like radiation and surgery in the future. Immunotherapies are different. They're given intravenously most of the time over between 15 minutes to 2 hours. Every agent is different. They're usually given between every 2 to 4 weeks, and some of them can be given under the skin. So very, very easy treatment, and it's a natural treatment. It helps your own immune system attack the cancer. Now, it does have downsides and side effects where the immune system may go a little haywire, but it's very easy to control that with things like steroids. So we're very, very used to using immunotherapy for different cancers at KU and combining them with other treatments. And it's a great, great option for patients.
Dr. Ashcraft, we're seeing this massive jump in colon cancer rates, especially in the younger age groups. I ask you this every single time, and I'm hoping one of these days you'll come on and actually know the answer to this question. It's one of the few questions you don't know the answer to. Nope. What's the theory?
They're the same ones we've discussed in the past. Processed foods, sedentary lifestyle, alcohol consumption. We really don't know the answer yet. It's going to tease out to probably what we're seeing in the literature now is it's going to be multifactorial probably. It's going to be a combination, kind of this perfect storm that's happening. But we're seeing it more and more and more, and if we don't get ahead of it, Dr. Al-Rajabi and I are running into a big storm as well as any other cancer treating doctor out there.
Kathy, you finished your treatment. How does it feel to hear those words from Dr. Al-Rajabi, cancer-free? You rang the bell?
I rang the bell. I'm currently still on immunotherapy till June. I've had no side effects, no complaints whatsoever. It gives you hope. And when you get a cancer treatment, probably hope is one of the best things you could possibly ask for.
And family has been there for you?
I've been very humbled by this diagnosis. I've had people stop me on the street that I may not know personally, but they know of somebody who knows me. And a lot of prayers said. So I'll take what I can get. You know, a year ago, you'll never hear me say, why me? Why not me? But you just don't expect that. And you have to make room for it in your life because it can be all-consuming. But it's part of staying alive. So you do what you have to do. But so far, so good.
Love to hear that.
Me too.
Let's get to a quick question and a comment from our viewer. Alice says, Dr. Al-Rajabi is my oncologist. He is the best, and I'm extremely grateful. And Jeremy wants to know, is there a difference between colon cancer and colorectal cancer?
Yes, significant. Colorectal cancer is kind of the all-summing term that we use. Because the two types of cancers genetically and morphologically are very similar and practically identical, as Dr. Al-Rajabi hinted to about the two trials being similar, but we treat them vastly different. Like in Kathy's case, straight to surgery. But if we would have had a stage 3 rectal cancer, we actually would have been discussing chemotherapy and radiation before surgery. Because the rectal cancer is held within the bony confines of the pelvis, and getting that local control, getting that to where when we go in there and operate, we don't leave any tumor cells behind is of utmost importance. We have a lot more freedom in the abdomen where the colon is, but the rectum being held in those bony confines of the pelvis, we usually use radiation and chemotherapy up front to stop it from coming back down there.
Dr. Al-Rajabi, thank you so much for being here with us today. What's the big takeaway? What do you want people to know?
Well, I think just, don't disregard any symptoms. If something persists for more than 2 weeks, please get checked out, especially if you have a family history of cancer. It could be as subtle as your bowels frequency changing or characteristics changing. I think always get checked out. And please, if you're 45, get your colonoscopy. Don't delay it. Once we snip these polyps out, it prevents these cancers from developing. You could really dodge a bullet with these colonoscopies. So, but if you are at higher risk, you may need your colonoscopies earlier. So be your own advocate. And if there's anything wrong, please seek advice.
Thank you so much. Dr. Ashcroft, what's the big message today?
Empower yourself. Know your family history. Know your risk factors. You guys just described that you had aunts, uncles. That's a strong family history. So you should empower your children and your other family members to know that history, which would then empower them to seek care sooner, seek their colonoscopy sooner, and be proactive. And then everything Dr. Al-Rajabi said, be an advocate for yourself.
You urged me to get my colonoscopy.
I did.
I did. I did it, and I did it.
Good person.
You are such a good
Thank you.
person. Doctor's orders. Kathy, so glad you're here in so many ways. What is the big message? What's the big takeaway from your personal story?
Looking back, it wasn't that I necessarily ignored things. I chalked them up as just normal run-of-the-mill stuff. And I tend to get up at 4, hit the ground running. The thing that truly made me stop and think was why was I wore out quickly. I didn't have the stamina. And kind of a funny side note, my son-in-law had mentioned to my daughter, he said, is your mother wearing a different kind of makeup? Because she's so pale. And I tend to have an olive complexion. And one day I had to go somewhere and I looked in the mirror and I thought, wow, I kind of look like a ghost. Those are things that stood out that I should, but that was close to the very end when this all came about. But just listen, pay attention, and do not ignore. And it can be something as simple as nothing, which would be great. But you've got to catch this stuff in time to treat it, deal with it, and move on.
I love you.
I love you more.
I don't get to say that to all my guests.
I know. On live TV, I've got proof now. You do love me.
I do love you.
Yes. Wow, what a birthday gift.
And I really like you.
Oh, I
And I like you too. See?